Hello everyone, I'm Ben Inti from the Indiana University School of Medicine. This lecture is a part of the SAEM narrated lecture series. Today we are going to discuss 3 ultrasound-guided lower extremity nerve blocks. Okay, let's face it, in the ED we see a lot of painful conditions. One of our primary objectives is to help relieve pain. We see a patient with an ankle like this, obviously he's getting pain medication, but can we do more? This is where an ultrasound guided block can help. Whether it is for analgesia or for reduction, blocking the sciatic nerve will provide the patient more relief than opioids alone. It's our job in the ED to get pain down to something manageable. Sure, we can snow everyone with opioids or benzo or Haldol, but nerve blocks can help out so much without the risk of respiratory depression or sedation. The main indication for nerve blocks is analgesia, whether it be for procedures or just relieving the patient's. So a couple of controversial points before we get going. The first is the danger of the anesthetic itself. In the ED, we typically have lidocaine or bupivacaine available. Lidocaine is relatively safe for the dosage we are using for blocks. Much higher doses are used when treating ventricular arrhythmias. Bupivacaine, on the other hand, does have known cardiotoxic side effects if indirectly injected intravascularly. The biggest fear is local anesthetic systemic toxicity. This, for all intents and purposes, is a bad sodium channel blockade toxicity similar to a TCA overdose. Overall, this is a rare event. The risk of this is greatly reduced when using ultrasound, as you can see where you are injecting. In 2012, an anesthesia study was published looking at 12,000 patients undergoing ultrasound-guided nerve blocks. Only 1 patient developed this local anesthetic systemic toxicity. This patient had a continuous femoral nerve block infusion and they think the catheter was dislodged. Well, we're probably not going to be doing continuous infusion in the ED. If you or your group are concerned about it, stockpiling intralipid in the ED may ease some of the fear, as there is some literature promoting that this is the treatment of choice if the standard treatment such as sodium bicarbonate are not working. The other controversy comes from what I hear from our orthopedic colleagues when I tell them I'm going to go do a block. Don't do that is their common response. Well, how are we going to know if they develop compartment syndrome? So this is their main concern. Well, there is sparse evidence in the literature mainly comprising of case reports describing patients developing compartment syndrome in the setting of having a regional block. All patients had breakthrough pain or increased analgesia need, meaning that compartment syndrome can be recognized in the setting of a nerve block. So while this is a consideration, it does not appear that there is evidence to support the fear of missing compartment syndrome. But just make sure you document a good neuro exam for consultants before you do the block if they have. All right, now that we've addressed some controversies, let's get going. Here are a few things you're going to need to do the block. Linear high-frequency probe is the probe of your choice. You're going to need a cleaning agent such as a ChloraPrep or betadine. A probe cover is controversial. I typically use Tegaderm. You also need a needle long enough to reach the target nerves. For deeper nerves, I typically use an LP needle. If you're going to use an LP needle, an optional but nice touch is to use an insulin needle to numb the skin area around your target. For more superficial nerves, a 25 gauge needle works great. There are some special ultrasound guided needles out there, but are not necessary. Lastly, you're going to need your anesthetic of choice. Lidocaine is faster on, but also wears off quicker. Bupivacaine has slower onset, but does last longer. The choice is usually case dependent. Okay, let's start with the most common lower extremity block I use. This is an 18-year-old male, comes in after a dirt bike accident. Looks painful, and it's a decent laceration, right? We all know how painful it is for the patient when the provider injects lidocaine directly into the foot or even around the surrounding tissue. But there's got to be a better way, and there is. The posterior tibial block would be absolutely perfect for this patient. It gives you great coverage of pretty much the entire sole of the foot. So with the landmark-based technique, you would feel for the artery and you inject posterior to it. But I tried this and I failed miserably over and over again. Well, there happens to be a reason why. A decent study from the anesthesia literature showed that 30 to 40% of tibial nerves run anterior to the artery, so you will actually be missing it with the landmark-based approach. Ultrasound will help ensure you get this block right. Before I start the procedure, I get everything ready. Room setup for blocks should be similar for all procedures. Position the ultrasound machine and your target area in clear line of sight, resulting in very little head movement during the procedure. This would be the same setup for all of these blocks. Also, get comfortable by raising the bed or grabbing a chair. Additionally, probe position is vital to nerve identification. In this image, note that the probe is positioned over the medial surface of the ankle, and the indicator is pointing to the operator's left side and posterior aspect of the ankle. Now that we're all set, let's see how easy it is for ultrasound to find the nerve. On this image, you see an artery, vein, and the posterior tibial nerve is to the left side of the screen. The nerve has the classic honeycomb appearance that peripheral nerves below the clavicle typically have. As you can see, the probe is in the transverse orientation. Probe indicator is to the patient's right or my left. You can use the in-plane or out-of-plane approach. For PT nerve blocks, I use the out-of-plane approach so that I don't have to move the patient as much. Either works just fine though. As you can see in this slide, I switched over to the in-plane approach. Here's why. In the distal nerves, either the in-plane or out-of-plane approach can be used. The out-of-plane approach requires less coordination and less patient positioning, but you can't always be certain what is around your needle if you lose track of your needle tip. On the other hand, the in-plane approach keeps track of the needle, but requires a coordination of both hands to keep track of the needle. This can be hard for some, as you would imagine. When we talk about the more proximal nerve blocks, I suggest using the in-plane approach to miss the large vessels sitting in close proximity to the nerves. So once you have your needle close to the nerve, I typically start by injecting under the nerve to push it a little bit more superficially. You will start to notice the nerve come into view as you add more anesthetic around it, giving it a large hypoechoic interface and hydrodissecting it away from. Try to get as much of a halo appearance with fluid all around the nerve as possible. Usually, if you don't get a complete halo, it's okay. You will only need about 10 milliliters of anesthetic for the posterior tibial nerve. Once you're done, go grab the rest of the supplies you need for the lac repair or foreign body removal. In about 5 to 10 minutes, the bottom of the foot should be anesthetized, and the patient will absolutely love you for this. Now let's move a little bit more proximally. I think you can all see that something's not right here. This needs to be pulled on a little to reduce it before it gets splintered if they are not immediately going to the OR. Sure, we can give a whole bunch of ketamine or propofol or even both. But when those wear off, the patient is going to be in a world of hurt. This patient, by the way, also had a blood pressure in the 90s when they came in. Sedation may not be the easiest, so enter the sciatic. As the sciatic nerve descends in the lower extremity, it splits into the peroneal and tibial nerves. So as you can imagine, blocking the sciatic nerve in the popliteal fossa will get you anesthesia to the entire lower limb, including motor and sensory, other than maybe a strip of skin on the medial leg and foot. This strip of skin is in the distribution of the saphenous nerve, which is part of the femoral nerve. Luckily, the osteotomes for the tibia and fibula mainly come from the tibial nerve. This means that blocking the sciatic nerve will block the actual bone well. The reduction can then be done usually with minimal pain medication or a small subdissociative dose of. Okay, when you're ready, the room setup should be similar to the other blocks and procedures. Keep the ultrasound machine in clear line of sight, but out of your way. You can perform this block with the patient supine and leg propped up like here, with the patient prone or with the patient on their side. Just know that if you perform the block supine, your image will be inverted on the monitor due to the position of your transducer. So be aware and be careful that if you advance the needle in an upward motion within the popliteal fossa, it will be displayed downward on the monitor. As you can see in this video, you want to see the same images as if you were doing a DVT study. Here you see the artery pumping. Then medially you can see the honeycombing of the tibial nerve as indicated by the arrow. At the end of this clip, you should see the peroneal nerve come into view laterally. Once you have found the tibial nerve, move the transducer approximately about 1 to 2 centimeters to find the peroneal nerve as it begins to merge with the tibial nerve to form the sciatic nerve. The peroneal nerve will typically come from the lateral side, which is indicated on the left side of this clip. And to make life a little easier for you, sometimes the sciatic nerve will even smile at you. Now that you have the sciatic nerve in view, simply mark where you plan on inserting your needle and visualize the needle in plane aligning the transducer footprint over the long axis of the needle. So in this picture on the right, you can see the LP needle was used for this block after numbing the skin. Keeping track of the needle, advance it towards the nerve. If you lose track of the needle, gently rock the transducer back and forth, or alternatively, fan the probe to see the needle better. Don't try to reposition the needle when you are in the soft tissue. You end up just bending the needle. Make sure to identify the needle in real time. If there is a significant difficulty to identify the needle, consider adding small amounts of anesthetic to hydrodissect, being aware that this may distort your landmarks. At the end of the clip, you should see anesthetic start tracking around the nerve. It is important to point out that injecting deep to the nerve will lift it toward the surface, making the rest of the block easier. Now that you have clear borders around the nerve, try to get the halo of anesthetic the best you can. This was about 15 milliliters of anesthetic. You can easily use up to 20 milliliters. The patient tolerated the block very well and underwent successful close reduction. Due to the long-acting nature of the anesthetic, the patient's analgesia also improved after being All right, this is our final case. An 80-year-old female comes into your ED complaining of left hip pain after she fell on the ice. The hip looks fractured even before you see the x-ray to begin with. You get the patient some pain medication, but she's still in pain. It doesn't work. You could continue to use opioids. However, we know that there's a much higher risk of respiratory depression in the elderly. So how about a nerve block? This will be a great idea. These work great with pain control in the elderly while awaiting for orthopedic surgery consult or for those long transports to a tertiary facility. There's a little bit of literature from the ED on these blocks. For instance, Baudouin et al. Published a nice trial showing that femoral nerve blocks work better for analgesia than opioids alone without any appreciable differences in adverse events between the opioid alone therapy. While it was a smaller trial and safety overall should not be judged, it does give us a look at the efficacy for analgesia. To actually do this block, you want to set up the same way we've talked about so far with the machine across the bed. To get the images you need, just start as if you were doing a DVT study or placing a femoral line. In this case, the transducer indicator is pointed laterally toward the operator's left. Just to clarify, this is the right leg. A transverse view and a lateral is toward the probe indicator. What you see is the neurovascular bundle. At this level, it's not uncommon to see nerves, arteries, and veins branching. There are two fascial layers that are in play here. Superficially, there is the fascia lata. Deep to that sits the fascia iliaca. It doesn't matter that you know the names of these layers, just that you need to get below the deeper fascia iliaca with your needle. Alright, once you set up and are ready to go, insert the needle in an in-plane approach, keeping track of the entire length of the needle as it traverses through both fascial layers. Inject about 15 to 20 milliliters of anesthetic below that deep fascial layer. The closer you are to the nerve, the less anesthetic you will need. If you look up the landmark-based approach, they advocate for using approximately 30 milliliters. This follows the old mantra of what I lack in accuracy I make up with volume, so be careful. Ultrasound allows you to be accurate, thus requiring less anesthetic. Okay, so this is a view of the anesthetic being injected, creating a nice halo adjacent to the nerve. This was sent to us by Dr. Mike Stone at Brigham and Women's Hospital in Boston, Massachusetts. Okay, so back to our patient. The patient's pain was much improved and did not require any more opioids while in the ED for another 4 whole hours. Well, that wraps up this lecture. Just a few take-home points. Nerve blocks, as you know, will help with pain control, whether you do it for a procedure or you're just trying to help the patient. As with any ultrasound-guided procedure, if you're not keeping track of your needle, you might as well be using the landmark-based approach. So keep track of your needle, please. And finally, go out there and use it on your next shift. It's amazing how busy we get, and so you tend to forget these things. Use it soon and practice often. Your patients will thank you. Take care.